So today we'll be talking about patient-centered diagnostic and therapeutic approaches for non-muscle invasive bladder cancer. I think it's a ripe time to be talking about this. We have so many exciting therapies, new biomarkers that are coming out, potential for precision medicine. But how does this all connect to the patient? How do we talk to patients about this? Really important to talk about. So let's kick it off with communication. We can start from the very beginning. Sima, let's say a patient comes to you with hematuria and we're just starting the diagnostics with CT urogram, cystoscopy. Can you walk us through how you discuss these things with the patient and what that discussion's like?
Sure. So I think for any of these discussions, it helps to have a framework to set the stage. And so the great news is that our national bodies have some pretty good guidelines that help you frame things to talk to patients so they understand why you're doing something and what you're sort of worried about, right? So I usually address the elephant in the room because they're actually coming to the cancer center to see me. And we talk a little bit about when patients have either microscopic or visible hematuria, what that implies and why they're talking to a urologic oncologist without a diagnosis, essentially. And then we talk a little bit about risk. We then from that, it's a different risk if it's microscopic hematuria versus visible, right? And I do also acknowledge that often we don't find a cause. In many of these situations, we talk a bit about the CT scan and what we really are looking for. You're looking for benign conditions like stones, why you need the urogram phase, because many have come with a standard CT or some with like an X-ray, and they want to know, well, why do I have to have this other test? So you kind of explain the rationale for that. Then probably the most time is spent on what a cystoscopy is and why you need it and how we perform it. A lot of patients ask, is it going to be tolerable, really painful or not? And you sort of go through those expectations. I think when people know what to expect and why you're doing things, it makes hopefully the process a little easier for them.
Yeah, I think that's really great. That's a really good point about mentioning that we might find benign pathology or nothing, because that can be frustrating for patients. But I tell patients that's a good problem to have if we're not finding anything too serious. So Pat, let's say that the CT urogram shows, nothing too remarkable. You're doing a cysto in the office and you see a tumor. How do you address that? Do you immediately tell the patient you're seeing something abnormal? Do you wait till you're all done to have that discussion?
Yeah, I think you got to read the room and kind of personalize that approach a little bit. Hopefully you've built some rapport with the patient. It might be your first time meeting him. Somebody might have referred to you just for the cystoscopy, but at least you've consented that patient and you've had the ability to kind of introduce yourself. I think it's important to describe exactly what you're seeing to the patient. Oftentimes, if the patient's not already watching the screen and the monitor, we do all these awake in our clinic. If they're not already watching, I offer them the opportunity to do so. And I'll describe, the lesion and kind of the architecture and what has me concerned. And if I'm, pretty certain that this is a bladder cancer, I try to use that actual terminology. I think some patients get a little taken back or kind of misled when you use things like mass or tumor or lesion, because their TURBT report comes back and you call them on the phone and say, well, you've got, high-grade bladder cancer. And they're like, wait a second, I have cancer. And it's like, yeah, we talked about this. You saw the tumor in the office. And it's sometimes patients need to actually hear that word. And papillary lesions, we can usually tell with a high degree of certainty that this is a concerning lesion. I try to describe exactly what the patient's seeing. I think it also helps, when these patients undergo surveillance scopes, many times they kind of buy in and they want to watch the screen, and they're pointing out different lesions as we're going and mapping the bladder. And we'll talk about each one and kind of, discuss what's concerning and not concerning about various lesions in the bladder. And that gets patients to kind of buy in. When they see a tumor, they understand the importance of the TUR and adjuvant intravesical therapy and those kind of things. So I kind of address it head on, but you got to individualize it a little bit for each patient.
Yeah, I've always kind of handled it the same way, describe kind of the features of it, and then, maybe go through some of the other aspects of what it is afterwards. We were at the Bladder Cancer Advocacy Network recently, and we had a patient advocate panel. And interestingly, there were some patients that actually said they'd prefer not to get that information during the cystoscopy. So we probably do have to tailor it based on the patient.
Yeah, and I think you also recognize when there's an equivocal lesion and we don't know, say a patient's heavily pretreated or they've got a patchy erythema and a history of CIS, you just admit that we're not certain based on the cystoscopic appearance, and we might need a biopsy or cytology to adjudicate those findings, and you just admit that. And again, patients are pretty understanding of that.
So next step, this patient's probably going to get a TURBT as the next thing. Are you counseling these patients on what the possibilities are from the TURBT from a path standpoint ahead of time, or do you table that for after the procedure?
Again, here's where you hope you have some relationship with the patient and their family, and you can kind of ascertain what their preferences are, but I usually just ask directly. So I will usually say we do need to do another procedure in the operating room to better characterize this. The majority of these are indeed cancers. There are some that are essentially benign or non-aggressive, and then there's a spectrum as you kind of move through clinical staging, right? And usually what I'll ask a patient is I'll let them know that there are many, many paths that you may need to walk down. I can certainly go over all those now, or if you prefer to take it a step at a time, we can do that too. And then they tell me which way they'd like to go, right? And some do want some framework of all the things, even to the diagnosis of possibility of like metastatic disease, right? Which hopefully you've had imaging in that beforehand, and that's not the case. But some like having all of that up front because it helps them cope. And others just want to do one additional step at a time and get the information in that way. If someone says, I would like it one step at a time, I'll then come back to them and say, I need you to know 3 important things about this TURBT. 1, like what we expect from it. And then, you talk about recovery, catheters, those kinds of things. 2, I talk about the possibility of gemcitabine, why or why not, at the time of surgery. And 3, I always bring up the possibility of needing to go back for a re-resection. I think that's important to let patients know based on findings that might be in their future as well. So that's sort of how I do that counseling and conversation.
Yeah, that's an awesome way to do it. Just ask the patient what they prefer and kind of let that guide the discussion.